Delivering babies and managing women's health is essential medicine, yet the business of providing that care operates with a massive, localized failure rate. While most specialties see a 5 to 10% denial rate, OB-GYN faces a towering 17 to 22%. That is lethal. 12% of annual revenue dissolves into unpaid claims. For a $1 million monthly practice, $50,000 vanishes every 30 days. When one specific medical specialty bleeds revenue at double the national average, the problem lies within the structural pathology of the billing process itself. The Global Maternity Package, CPT code 59400, appears as a single block but bundles dozens of interconnected services. When a situation deviates from a routine birth, like a complication or insurance change, that package must be unbundled with specific surgical modifiers to get paid. High file volume forces in-house billing teams to process claims under strict time pressure. When speed takes priority, nuanced unbundling requirements get missed. Relying on in-house generalists is expensive. A single full-time biller carries a loaded cost of up to $75,000 a year, and when they inevitably leave for another job, all their institutional memory goes with them. A generalist's capacity is structurally incompatible with the depth of OB-GYN coding logic. The result is a permanent compounding backlog of denied claims. To navigate the unbundling requirements that a generalist staff might miss, some practices are shifting toward a specialized embedded model. This operational structure uses an external team of AAPC and AHIMA-credentialed experts who work exclusively inside the practice's existing electronic medical record system. Because this dedicated team handles nothing but OB-GYN claims all day, the expertise is already built in. Turnover costs and training gaps disappear instantly. Patient data stays secure through a compliance-grade infrastructure protected by SOC 2 Type 2, ISO 27001, and HIT-Rust frameworks. This model functions as a fully engineered billing department plugged directly into the practice's own operational nervous system. The first line of defense is daily pre-submission claim scrubbing. The team actively hunts for modifier errors and unbundling exceptions before claims ever leave the building. AI acts as an automated auditor. Smart routing flags complex cases, diverting them to specialized verification tracks for human review. This radar chart maps denial root causes against specific payers. By tracking why providers reject claims, the system builds proactive rules against institutional quirks. Medical billing stops being a messy, reactive cleanup job. It becomes a predictable, engineered revenue pipeline. With the new workflow in place, volume no longer overrides precision. Error rates plummet below 1%. The financial contrast relies on the efficiency of scale. By utilizing a per-seat model rather than a loaded salary, the cost of a specialist drops to roughly $20,700 a year, far below the $75,000 required for an in-house hire. This model allows for deeper expertise at a lower entry point. When you add the recovered revenue, the $50,000 a month that was previously lost, the balance sheet tips back to profitability. True financial optimization in healthcare requires permanently eliminating avoidable structural waste. The coding rules for OB-GYN are only going to get more intricate. Relying on specialized expertise is mandatory for survival. Implementing that expertise takes exactly 14 days. In 2 weeks, EMR access is established and custom protocol training is fully deployed. Practices can initiate a 14-day risk-free pilot right now and stop leaving their hard-earned money on the table. Securing a practice's revenue requires making a deliberate, specialized operational choice.